Alright, welcome back everybody. So last video we discussed spermatogenesis. We just had gotten started with reproductive physiology, and we looked at a bunch of stuff, right? So generally speaking, it took us a while to get through the spermatogenesis, really grasp the actual genetics to it, right? With the whole mitosis and meiosis that's occurring. So make sure you truly understand the actual divisions and how the different divisions are labeled, right, based off of 2N and 2C, stuff like that, right? So 2N, 2C is only seen once. Remember that. 2N, 2C is only seen once, and that's actually your spermatogonium, the guy that undergoes mitosis to make more spermatogonium, all right? After that, once you're in here and you're becoming a primary spermatocyte, you've already doubled the number of chromatids you have, right? So now you have sister chromatids. Right, so a number of chromatids, the 2C became a 4C, double the number of chromatids. After that, you start doing meiosis, at which point you're always going to keep having something, right? So the first time you have both things, so 2N became 1N, the 4C became 2C. Now you have two cells that are no longer identical to the original because this is not mitosis, this is meiosis, right? You made these two guys, and then these two guys undergo meiosis too, where again things get divided. The sister chromatids are split up, so now the 2C becomes 1C, and now you have four haploid spermatids that are going to be equipped with everything they need to become a spermatozoon, which is going to be zooming to the egg, right? We looked at some Kaplan notes. We did this really nice practice question here, which helped us connect reproductive pathology with congenital adrenal hyperplasias, right? Because over here I described that 21 and 11 hydroxylase deficiency. Remember that the number 1 is like an arrow pointing up, right? And it's GFR. The F is always low in congenital adrenal hyperplasias, but the G and R is either going to be high or low depending on what enzyme is missing. And in both 21 and 11, the second digit is the one pointing up, so the androgens, reticularis, the androgens are high in both of these guys, right? And excess androgens, as you can see in choices A and B, excess androgens in a female will give male type ambiguous genitalia, right? Because too much testosterone. Whereas in 17 hydroxylase deficiency, where only the first one is up, which is the G, so that's a lot of aldosterone, right? But the latter two are down, so not enough testosterone. 17 hydroxylase deficiency has low amounts of testosterone, so that's like as choice E, where a male might not develop their external genitalia too well, right? Because they need a high amount of testosterone that becomes DHT as well. And then we looked at estrogen and progesterone are two key players in the endocrine manner of reproductive, right? Really important to understand how they work, the things they can do, especially when we came to progesterone. We saw that there was a well, actually, with both of them, estrogen and progesterone, we saw that there was a GIT connection here in this question right here. Both of these questions, actually, both the URL and the AMOS question, went ahead and showed us how imbalances and excess interplay between estrogen and progesterone can actually lead to gallstones, right? And that's a very important thing to watch out for, right? Because step 1 loves anytime they can combine 2 or more systems to give you a really interesting question and really, like, it's like a curveball, right? Just throw you off guard. So if a question starts with reproductive stuff, right, with uncomplicated pregnancy, blah, 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 and then all of a sudden shifts gears to patient having gallstones, you have to be ready to know that estrogen causes cholesterol hypersecretion and progesterone causes gallbladder hypomotility, allowing all that cholesterol to sit in your gallbladder, right? And then you end up having gallstones. Right, so now all of that was done, right? That's a tiny revision. I remember, lately in every video I do a tiny revision of what was discussed in the video before. It's always important to do such things when you're studying yourself too. Always revise what you studied the day before moving into the new things for that day. Okay, so now we can go ahead and get started with the oogenesis. So after estrogen and progesterone, the book continues to talk about the production of the ovum, right? So primary oocytes begin meiosis 1 during the fetal life. Now keep in mind, there were some things we talked about in the last video that I said are going to be very different between males and females, right? When we looked at the male stuff with spermatogenesis, we said that the events inside the nucleus are the same for males and females, but the division of the cytoplasm is different in both genders. So that's one thing we're going to see. Second of all, spermatogonia and oogonia or somatic cells, right? That's the stuff right here that undergoes mitosis. And then the really important thing was this last sentence right here. In males, meiosis 1 does not start until puberty, right? But in females, remember, women are born with all the ova they're going to have, right? So primary oocytes begin meiosis 1 during the fetal life, right? In fetal life. We're now waiting for puberty here. And they complete meiosis 1 just prior to ovulation. So basically you make a bunch of oocytes that are just going to sit there, and then they finish meiosis 1 right before ovulation. Meiosis 1 is arrested in prophase 1 for years until ovulation finally occurs, right? And meiosis 2 is arrested in metaphase. Metaphase 2, of course, but metaphase, it's in the second meiosis now, so that's why it's the metaphase 2, until fertilization occurs, right? So an egg met a sperm. If fertilization does not occur within 1 day, the secondary oocyte degenerates. All right, so that's all you have. You have 1 day to get pregnant, which is why it is said that getting pregnant is, 1, not easy, and 2, completely a game of chance, right? But you have some ways to go ahead and kind of calculate things and figure out when that egg might be there, and that's the day you try to get pregnant. So now they go on to show you a similar diagram as we saw with the spermatogenesis stuff, except here you're noticing a lot of these guys are crossed out. These are polar bodies, and that's the part, the other part that's different, right? So not only does stuff begin here way before puberty, in fact it begins in fetal life, second of all, the cytoplasmic division is very unequal, right? You can see these guys are smaller than the other ones up here. So Kaplan had good notes on this, and then keep in mind again the naming of these different stages and the labeling of ploidy and chromatids, right? 2N, 2C again over here. This is undergoing mitosis to make more of itself until finally it undergoes meiosis, right? And it's going to start preparing for meiosis. You double the number of chromatids you have, do meiosis 1, do meiosis 2, and then you're up to here. Right, so in females, the formation of primary oocytes begins around the 5th month of development. By time of birth, all the oogonia have either differentiated into primary oocytes or have died. So in the newborn female, there are no oogonia. Keep that in mind. Newborn female does not have any oogonia. Okay, but a newborn female is born with all the primary oocytes she's ever going to have. Meiosis is halted at prophase 1 until after puberty. Each month after puberty, one of the primary oocytes will continue the meiosis, complete meiosis 1, and then enter meiosis 2 and stop at metaphase 2, which is then going to get ovulated, right? It will then remain halted until menstruation ends or fertilization occurs. When fertilization occurs, metaphase 2 then continues to finish meiosis 2. In the second meiotic division, we get 4 cells, and each has 1 chromatid. And that's right here. Each has 1 chromatid, making it 23 1N 1C, right? 23 single chromatids, 1N 1C. The definitive gametes. In males, we end up with 4 sperm cells. In females, the primary oocyte divides the cytoplasm unequally, so almost all the cytoplasm goes to 1 cell, which is denoted the secondary oocyte. The others with lesser cytoplasm are called polar bodies, which are the ones that are crossed out. They're not really capable of reproduction or making kids or anything like that. So those just end up dying. So in females, there's 1 secondary spermatocyte. Sorry, what did I say? 1 secondary oocyte, excuse me. Oocyte. There you go. 1 secondary oocyte, which divides again in meiosis 2. Once again, giving unequal cytoplasm so that only 1 gamete is formed and a second polar body is made. That 1 gamete will become the ovum. Okay, this guy became the ovum. That's it. This polar body just gave more polar bodies, and it was all just a waste. Okay, so that's really something you want to make sure you understand. Again, these simple genetics type questions where they want to test you on the number of chromatids and ploidy is a silly thing, right? And you really want to make sure you don't mess that up. It's more of a understanding rather than memorizing kind of thing, right? And if you've forgotten what mitosis, meiosis look like, then you definitely want to make sure you go back and revise what is the steps of mitosis, right? And what are the steps of meiosis and how they're different from each other, and how the DNA is replicated and then divided out and proportioned out, because that's basically all that's happening here. Okay, so that's your ovum now. So the one ovum is made. We made the spermatocyte already. Also, down here now becomes the next big topic that's going to be on your step one, menstruation, right? So first thing they talk about here is ovulation. How do you have ovulation? High estrogen and high gonadotropin releasing hormone receptors on anterior pituitary. Estrogen surge then stimulates LH release, which causes ovulation, rupture of follicle. There's going to be an increase in temperature, which I told you guys yesterday when we were looking at progesterone that this is slightly important. Increase in temperature due to progesterone. And that's basically your whole process of ovulation. It's a quick little thing that happens. And a lot of women can actually feel this, right? They know they're ovulating. They know they're ovulating. They'll feel a little hotter. They get some kind of feeling. And then, of course, there's some other real feeling you can have, which is your middle schmerz, right? Middle schmerz is a transient mid-cycle ovulatory pain, classically associated with peritoneal irritation, right? Follicular swelling, rupture, fallopian tube contractions, and can mimic appendicitis. And this middle schmerz thing, whichever side is happening on, that's the side you're ovulating from. That's really all it is. It's rarely ever is so big of a problem that you need help, and it's just going to end the same day. It shouldn't continue to more than one day, right? Because ovulation is just a one day, not even a one day thing. It occurs really instantly, but it's only on that one day. It's not like you're ovulating multiple days in the same week, all right? So this is an embossed graph of the same stuff that we have here, right? So I put it here because I liked the way this was also made. Okay, so I'm going to make it bigger just to show you guys a little. Right, so this embossed curve does a pretty nice job kind of showing you the same stuff they're showing on the next page, but in a different manner, right? And sometimes some people like looking at things in different manners. The color coding here is a little different. The labels are pretty much all the same, though, nothing major. And up here, you get to see a lot more about how these things are developing, right? So you have your corpus luteum, which again, when it is no longer needed, becomes corpus albicans. So these are names you do need to know. You do need to know those names. On the left, we have an embossed question that was very significant because this is definitely something you can imagine you're going to have on your step one. So a healthy 31-year-old woman comes to the physician because she's trying to conceive. She's currently timing the frequency of intercourse with at-home ovulation test kits. An increase in the levels of which of the following is the best indicator that ovulation has occurred, right? And look, 39% of people picked progesterone, which was the correct answer. 51% of people, though, got it wrong and chose LH, right? Because everyone knows that the LH surge is what causes ovulation, right? But the question is asking, how is this at-home ovulation test kit working? If you were making a test kit, look at this image, right? This is where ovulation occurred in the middle here. If you were making a test kit to check if ovulation has occurred, how would you do so, right? So that means that after ovulation, you're going to be checking for some hormone. And after ovulation, you can see LH goes back to pretty much normal, right? LH surge, yes, it caused ovulation, but the test kit to see, hey, have I ovulated yet, would be testing for progesterone. You can see progesterone gets significantly higher after ovulation occurs. Why? Because after ovulation, you're ready for gestation, progestation, right? You're ready to get pregnant after ovulation. So LH surge, yes, LH surge induces ovulation, but right after ovulation, it goes back to zero, right? Or back to normal is what I mean. So you can't really have a test kit checking for LH because it's just going to not detect any LH. Now, if you're testing every single day, right, and you one day catch a high surge of LH on it, that's different. But the way this question was worded and the reality of the matter is, after ovulation, the only hormones that are significant are progesterone and estrogen, and you could tell progesterone is pretty much double the amount of estradiol here. So they explain the level of this hormone increases right after ovulation. If fertilization and implantation do not occur, the same hormone decreases in concentration, causing the endometrium to be shed, and that's progesterone. Towards the end of the follicular phase of the menstrual cycle, a peak in estrogen levels triggers an LH surge which induces ovulation. The corpus luteum then begins to produce progesterone. An increase in progesterone levels is therefore an indicator that ovulation has occurred. Approximately 24 to 36 hours prior to ovulation, a peak in LH occurs, which induces the rupture of the Graafian follicle. Following ovulation, though, the LH level rapidly decreases. Since the LH peak is very short and occurs prior to ovulation, it is not a reliable indicator that ovulation has occurred. Right? It just doesn't do the job for you. So at that point, the best thing to do would be to check for progesterone because it stays high for a longer period of time. Right? Progesterone is high for all of these days, clearly from like day 15 to past almost up to like day 22, 23 over here. So it's a couple days in between for you to check how high your progesterone is, and if your progesterone is high, you know you're done ovulating. Now back here one more time, and this is a very important page 616 to come back to. Estrogen and progesterone are discussed here. They tell you all of that here, right? So progesterone, they let you know that during the luteal phase, it prepares the uterus for implantation. It stimulates the endometrial glandular development, so you can have your implantation ready, and it's doing a bunch of things to prepare you for pregnancy, right? So if progesterone is high, that's how you know you've ovulated, and they tell you that here too, right? High progesterone is indicative of ovulation, and that's basically what this AMBOSS question was about. Now on the next page, we can finally actually dive into truly understanding, memorizing, and then keeping in mind the whole menstrual cycle. Okay, the follicular phase can vary in length, but the luteal phase is 14 days. So ovulation plus 14 days is what equals menstruation. Follicular growth is fastest during the second week of the follicular phase. Estrogen stimulates endometrial proliferation, and we know this, right? Because hyperestrogenic states can lead to endometrial hyperplasia, right? Which is a risk of endometrial cancer. Progesterone maintains endometrium to support implantation because it's pro-gestation. If you don't have enough progesterone, you cannot get pregnant. Right? So that's a very important thing, especially in OB gynecology, where women come in saying they're having difficulty getting pregnant. So you might want to give them more progesterone. Now, phases of the ovarian cycle, this image kind of like really lays it down for you really well, shows you everything. And the reason I kept the AMBOSS image is because they put all the curves on the same line. So LH, FSH, estradiol, and progesterone are in the same place, so you can see how they all are related to each other. Whereas here they've done it separately, so LH and FSH is up here, estrogen and progesterone is down here. So you can see estrogen is higher before ovulation, right? Super high, and that high estrogen is actually what induces an LH surge to have ovulation occur. Once ovulation occurs, estrogen goes down, of course, LH goes down, and FSH has a slight decrease. But for the most part, FSH stays, pretty leveled the whole time. And after ovulation, progesterone is really high. Okay, so I put that note here too, that the body temperature rises by about 1 degree Celsius at ovulation. And over here, that the LH surge causes ovulation, but the increase in progesterone is the best indicator that ovulation has occurred. Repetition is key, and the more times you see that, the more likely you are to remember that. Right, so it all starts from the hypothalamus, though. So remember, if something's wrong in this level with the hypothalamus or the pituitary, this entire cycle gets messed up, right? Because this is all, the anterior pituitary is all where GnRH and FSH and LH, right, are all coming from. So GnRH from the hypothalamus, FSH, LH from the anterior pituitary. These are two different levels where you can have some kind of pathology. If something is wrong there, the whole cycle gets messed up. Now, assuming all of this is okay, then you move on to what else could be wrong, right? Because then FSH and LH are also directly related to progesterone and estrogen. And we saw that too on the last video, right? Up here, LH was important over here for theca cells. This is mainly theca interna. Remember, there's a theca interna and externa. The externa doesn't really do much. This is the theca interna cell where LH allows you to break down cholesterol to androstenedione. Then FSH in granulosa cells causes that androstenedione to become estradiol or estrone, whatever you need, right? So both of these guys come together, and FSH and LH are both necessary for making cholesterol into estrogen. So right here I wrote a little information about this phases of the uterine cycle, right? Because you get questions on this. You're going to get questions where they're going to try to describe to you what this coiling and all of this looks like, what the layer of the endometrium looks like, and then you have to tell them, okay, is this menses? Is this the proliferative phase? Is this the secretory phase? Where are we, right? And yes, the three phases are very different from each other. They're extremely different from each other. So over here I wrote normal proliferative endometrium consists of uniform, non-branching, non-budding glands evenly distributed throughout a uniform stroma. Right? That's the proliferative endometrium. That's just right here. Okay? Everything is uniform, non-branching, non-budding. Everything is just plain, simple, flat. Right? And you can see that it's only near the end here where stuff starts to change. But for the most part, this is how these three guys here, this is how your proliferative phase is going to generally be like. In the mid-proliferative phase, and that's after the third one, the fourth one, this phase right here, in the mid-proliferative phase, the glands are more tubular, narrow, and lined with pseudostratified, elongated, mitotically active epithelial cells and a stratum functionale layer with compact, non-edematous stroma. Right now, ovulation occurs. Right after the mid-proliferative phase, you're done proliferating. Ovulation occurs. Ovulation is at the late proliferative phase, which has coiled glands and occasional cytoplasmic vacuoles in the glandular epithelium, and that's what we're seeing here. These big vacuoles. In the secretory phase over here, now notice there's a major difference from here and these guys. Right. In the secretory phase, glands acquire large cytoplasmic vacuoles, really big ones, and more than one, but of course for visual purposes, they've only made them bigger, not added a bunch. Right? And here they don't really show the vacuoles at all. So that's something I would, fix up in the emboss image if anything, which is why I kept both images. It's nice to have them both. Neither one image is perfect. Cytoplasmic vacuoles that release glycogen-rich mucus, and the stroma becomes edematous with prominent spiral arteries, and you're going to see that in your answer choices, extending to the endometrial surface, right? Very, very spiral arteries. You see how much this is like corkscrew kind of thing happening. And if fertilization and implantation don't occur, then you move on to menses, where again you can see all of it is degenerating. Okay, so the proliferative phase is broken down into a couple of stages, and then your secretory phase is where you have the super spiral arteries, right? And you get questions where they ask you about these things. So now for the rest of this video, we're going to spend a little bit of time really mastering this stuff by looking at a couple practice questions that really show you how this is going to get tested on your step one. So first question right here, these two are both questions from UWorld that are highly relevant, very important, clinically important, as well as test-wise important. First one, a 27-year-old woman comes to the office for evaluation of fertility difficulties after 3 elective first trimester abortions in her late teens and the use of oral contraceptives since age 22. So basically what you're understanding here is that she's perfectly fine, but she elected to get abortions because she probably wasn't practicing safe sex. She probably was not ready for a baby. It could be any reason. Point is, it's her body. She can do whatever she wants to. First trimester abortions, okay? She is not having any periods even though she stopped contraception a year ago. Now that sentence is there to confuse you, okay? Using oral contraceptives does not mean that when you stop using oral contraceptives, some kind of issue is going to occur. So even though she stopped using oral contraceptives a year ago, she's not having periods, that's a different issue. It has nothing to do with oral contraceptives. Her TSH, FSH, LH, prolactin, and beta-HCG are all normal, which means everything's okay. Remember that the thyroid, when we did endocrine, thyroid hormone is something you check for with almost any pathology because it's such a huge systemic hormone, right? It affects everything. Affects everything. Brain maturation, development, hormonal balance of all the other hormones. Everything gets affected, your entire body. As part of our evaluation for amenorrhea, 10 days of oral medroxyprogesterone is administered, right? Like we just said earlier. If a patient is having trouble getting pregnant, give them progesterone. A few days after completing her progesterone course, the patient has moderately heavy bleeding with some cramping, which basically means she got her period. What endometrial process caused the bleeding? And this question just completely shifted gears, right? It went from a very reproductive, high-yield topic to a very pathology-based kind of pathoma stuff. What endometrial process caused bleeding? Well, menses is apoptosis, and that's what the answer was. And yes, the other answer choices that were in this question were actually confusing enough for a lot of people to end up, choosing one of those. But it's just apoptosis. Menses is apoptosis. Always remember, if you have a part of your body that you're not using, it just dies, right? It's not necrosis or any of those other weird things. It's just apoptosis. You're not using the endometrial layer. You're not getting pregnant. Let's throw this out because it's wasting a lot of blood and resources, right? Progesterone secretion in the luteal phase transforms the endometrium from proliferative to secretory, so implantation can occur. Exogenous intake of progesterone for about 10 days also matures the endometrial lining. When the endometrium is no longer exposed to the progesterone, like in this progesterone withdrawal test, the prostaglandin production increases. And now this, I put it in red because this is very important to know. Prostaglandins, always relevant, right? Important in every kind of chapter we've been in, cardiovascular, GIT, everywhere. Prostaglandin production increases when the progesterone level goes down, leading to vasoconstriction of the spiral arteries. Okay, and this is something that's not really taught in the book. It's not in first aid. It's not in any of the other sources I've looked at, but UWorld put it here so you can know it. Progesterone withdrawal increases metalloprotease secretion by endometrial stromal cells, degrading the extracellular matrix, leading to apoptosis of the endometrial epithelium. The net effect is degeneration of the functionalis layer, which slows away as menstrual flow. So the real takeaway here is that she's actually okay, but for some reason she's not making enough progesterone, right? So when she's ready to get pregnant, we'll basically tell her, all right, here's some progesterone, you take it, you should be able to get pregnant, everything should work out, okay? That's all her problem is. Other than that, like, discontinuing OCPs is never related to no longer having periods. That's not normal. It can happen, but it's not normal. That means something else is wrong. And when the progesterone level goes down, so now there's a little more information to add into here, right? You can see after this point right here, right here, which is not labeled in days on this image. So that's another thing I don't like about the UWorld image. I mean, the first aid image. But right here, so 14 days we know is, going to be starting, because look, day 14 is where ovulation is labeled, right? So ovulation is right here somewhere. So a little bit after ovulation, when the progesterone level goes down, prostaglandin synthesis is increasing. And prostaglandins are going to cause these big spiral arteries in the secretory phase to vasoconstrict. By vasoconstricting, not enough blood is going to be coming here, and then you start having menstruation. Okay, so that's something that you can get a silly question on. You want to make sure you're ready with that. That's a really nice high yield point. Next question here is similar kind of thing, but a different scenario, right? So now you have a 14-year-old girl who is brought in for routine checkup. When asked about her periods, she says that she does not get them every month. When she does have her period, she bleeds for 7 to 10 days, which is more than normal, and needs to use nearly twice as many tampons a day as her older sister. So clearly she's bleeding very heavily. She also complains of occasional spotting that happens outside of her normal periods. The patient underwent menarche last year, and her last period was 6 weeks ago. She eats well, exercises, has no past medical history, BMI is fine, 25, right? She's not obese. What is the most likely cause of her complaints? So again, looks like everything is fine, right? But she's skipping some periods, and then all of a sudden she has periods that kind of look like they made up for her missed periods, right? So the answer here was just anovulatory cycles, and this can occur. This is a young girl that just started her menstrual system, right? Her menstrual phase and all of that stuff. She just had menarche last year. In most women aged 20 to 40 years, periods are very consistent and last 24 to 35 days, right? Which basically is talking about the whole thing, not just the menstrual part. With menstrual flow ranging from 4 to 6 days, okay? However, adolescents typically have an immature hypothalamic pituitary ovarian axis for several years following menarche, and this is different for everyone. During this time, they may have longer periods and irregular bleeding due to anovulatory cycles. In the absence of ovulation, the ovarian follicle does not degenerate and becomes a corpus luteum, so no progesterone is produced and estrogen remains persistently high, causing the endometrium to remain in the proliferative phase. When the period finally does happen, it will be more than usual, right? Heavy bleeding. Because keep in mind that as estrogen is increasing, you can see the proliferative phase is just increasing. It's after the estrogen goes down that you have to make progesterone, right, from the corpus luteum. And when that progesterone is coming out, right, you can maintain this. And of course, keep in mind the corpus luteum is also making the more estrogen as well, which keeps you going also. But as soon as all of that goes away too, then you finally end up bleeding, okay? And any derangement in these productions can cause anovulatory cycles. This is a topic that will be discussed further down in first aid as well, but just good to see it here and see it again later on as well. Repetition is very, very important. Now, this is another typical type of way you can get this question on, right? You can get a graph like this, where they show you LH, FSH, right? They show you estrogen and progesterone. They label different parts of the cycle for you, and then they want to ask you what each of these parts are about. This is something you should be able to do yourself by the time you're ready, right? So you should be able to print something like this out for yourself or write it out for yourself, and then label what's happening at each one of these phases. And on top of that, also draw out how the endometrial layer should look like, right? And where the hormones are coming from, everything. You should be able to fill this in basically, right? So they gave you a question in AMBOSS that an investigator is studying the menstrual cycle in premenopausal female volunteers with normal ovarian function. Endometrial biopsy specimens are taken from each volunteer every 6 days for a month, and capillary lumen area and endometrial layer thickness are measured. Microscopic examination of one such specimen shows condensed endometrial cells with deeply eosinophilic cytoplasms and basophilic fragmented shrunken nuclei. Right? So they showed you a microscopic examination of the endometrial layer they're getting this biopsy from. This is most likely to be seen in which of the following parts of the menstrual cycle. And then they give you this entire cycle, right, labeled with days. Now, where would you see this? What part will you see something like this in? And they don't give you any kind of pathology or anything. So you're assuming something's normal here, right? Condensed endometrial cells, deeply eosinophilic cytoplasm, basophilic fragmented shrunken nuclei, right? What is this describing? So you look at all your answer choices, right? And it should come immediately when they mention the fragmented shrunken nuclei. The biopsy specimen shows nuclear shrinkage, right, which is pycnosis, and fragmentation, which is karyorrhexis, all of which are features of cells undergoing apoptosis. Endometrial cells undergo apoptosis just prior to being slowed off. So the answer is F, right, which is right here, right? Because remember, this C layer is basically where ovulation occurred, right? And then at D, your corpus luteum is being developed. At E, your corpus luteum is now secreting more levels of progesterone, and well, it's actually starting to secrete at D, actually, right? And by E, you're in the phase where you're basically the secretory phase, right? You're going to have the spiral arteries and all of that ready for implantation, good to go. At some point, though, no fertilization occurs. Both progesterone and estrogen levels go down. Corpus luteum gets degenerated to corpus albicans. Right? You should be able to fill all of that into this image. Once you can do that, you know you've memorized it, you've mastered it, you're ready to go. Right? And remember also at this point that it was the prostaglandin synthesis that started increasing now, causing vasoconstriction of the endometrial spiral arteries, and then you get menses. Right? And then, of course, feel free to pause to check it out, but I've labeled what all the others are here too. Okay? So that's a whole different thing. Make sure you know this, right? This is just one topic, and this is also one of those topics that you just study once and never come back to again. I've said that a couple times throughout this full FA playlist. Many things require you to come back over and over, but this should be a one-day thing that you just master on the day of, right? Don't move forward in reproductive until you've mastered the interplay between estrogen and progesterone, what each of them do, how they're related to the endocrine chapter, how they're related to GIT with the gallstones we mentioned earlier, and then how they allow you to get pregnant, right? How the whole menstrual cycle works. The last thing is a little revisit of receptors, right? Receptors are always tested. Step 1 loves asking questions on it because receptors are often so intimidating to most people. And the hardest of all receptors to know is actually the IP3 stuff, okay? So let's take a look at this question, and then I'm going to go back to where all the receptors are discussed in endocrine. So this AMBOSS question says, 30 minutes after vaginal delivery, a 6-pound, 2-ounce newborn at term, delivery of a 6-pound newborn at term, a 25-year-old woman, G1P1, has heavy vaginal bleeding, okay? So post-delivery bleeding. Her pregnancy was complicated with preeclampsia, which is hypertension, and that's never safe. Her pulse is 111 per minute, and blood pressure is 95/65 now. Physical exam shows a fundal height 2 inches below the xiphoid process of the sternum. A drug with which of the following mechanisms of action is most appropriate for this patient? So the physical exam here, whatever it's telling you is basically telling you that it's not supposed to be like that. That's basically it. And the main takeaway from this question is that she needs something to stop bleeding, right? You need to just close everything down. The delivery is done. So the correct answer for this question was activation of phospholipase C, right? And a lot of people got this question wrong because it's really hard for some people to remember the phospholipase C stuff. This patient's development of tachycardia and hypotension in combination with a uterus that has not contracted, right? That's what the physical exam is telling you. The uterus has not contracted shortly after childbirth is highly indicative of postpartum hemorrhage due to uterine atony. And remember, postpartum hemorrhage is really scary because that can lead to Sheehan syndrome and it can even lead to death of the mother. Oxytocin, which binds to a GQ protein coupled receptor on uterine smooth muscle, is the first line drug for treating postpartum hemorrhage due to uterine atony, no tone in the uterus. Activation of the oxytocin receptor activates phospholipase C, and all of this is being seen in this image over here from MBOS. Activates phospholipase C, which cleaves membrane phospholipids into IP3 and DAG, right? And that's what's happening here. The PIP2 got cleaved into DAG and IP3. IP3 goes over here and causes increase in intracellular calcium in here, right? And then DAG goes down and uses protein kinase C to also increase calcium. Remember, calcium is related to contraction. So that's what this is all kind of describing, right? Contraction of these fibers would constrict the blood vessel and effectively decrease uterine bleeding. Now, how do you memorize this? Well, this is one way to memorize it, right? Because here, this is not just a straightforward pharmacology receptor question. There's an actual clinical scenario involved, and you should remember that for this clinical scenario, postpartum hemorrhage, you gave oxytocin, right? Anything that would cause more tone in the uterus. And oxytocin, how do you remember that? How does it work, right? So this one is actually, in my opinion, one of the harder ones to memorize from this page, right? So from this page, signaling pathways of endocrine hormones, right? Cyclic AMP, cyclic GMP, intracellular receptors, those three are the easiest ones to memorize. And you can spend an entire day looking at it, but this is something that you have to constantly come back to, revise, reiterate, look at it, tell yourself what's happening, come up with memorization tools, but you have to come back over and over. This is not something you'll just memorize in one study. But cyclic AMP, GMP, and intracellular receptor are the easiest ones. Receptor tyrosine kinase is the second easiest thing, right? Insulin and all the other growth factors with the MAP kinase. So think growth factors or get found in the MAP, or my thing where I basically say insulin is anabolic and makes you grow, or you need a MAP to grow is the thing I usually use. I have it written here, right? You need a MAP to grow your nation, something like that. Insulin is also a growth factor in a sense. The non-receptor tyrosine kinases, you can see these guys are pretty different. JAK-STAT, right? Prolactin is significant for what we're doing right now. And then immunomodulators, and then all these other, cytokines, growth hormone, CSF, erythropoietin, thrombopoietin, and a bunch of other stuff. So this one is like a little weird, right? But the weirdest and the hardest one is IP3, because in IP3, the things that are here are completely, unrelated to each other. It's just random shit. GnRH, oxytocin, ADH, TRH, histamine H1, angiotensin 2, and even gastrin. So there's no easy mnemonic to memorize these guys, and GoHag doesn't really per se work. IP3 works with GQ, okay? And this, again, is related to what you do in pharmacology, autonomic drugs, right? The second page right here, when we memorized all of this stuff at the bottom, we came up with, can I have 1M&M? To remember how GQ works, right? Because the question mark is for GQ. Right, this question mark reminds you that this must be GQ. Can I have 1M&M? And it's H1, alpha 1, B1, and then M1 and M3. All of those guys, right, work with GQ phospholipase C. Okay, for more smooth muscle contraction via MLCK, myosin light chain kinase. The other guys are also pretty easy to memorize because people who are 2-MAD inhibit themselves, and that's your M2, alpha 2, and D2. Anything else that's left, all your beta receptors, D1, H2, V2, they all use GS for more cyclic AMP activity. Okay, so over here, although oxytocin isn't on this page, oxytocin also uses GQ for phospholipase C activity, as we just saw on the page we were in with reproductive. Okay, so you gotta make sure that you can make those connections. Spend a little bit of time today to really get this down, get down the endocrine stuff for the other receptors. And again, you're not going to memorize it in just one stare, right? You're not going to memorize it in one stare. You need to write this out for yourself, reiterate to yourself, look at this every moment you can, really. Maybe end every day of your studying by revisiting this page. And then we already saw some of this. This is easier stuff, the sex hormones, right? the androgen hormones, all of those guys have a cytoplasmic receptor, which then translocates into the nucleus. This we saw a question on yesterday in the last video right before this, and it was also pretty high yield. Okay, so you want to make sure you get that stuff down because it's not that hard, and you don't want to lose those memorization questions down, right? This is literally just pick activation of phospholipase C. There's no thinking involved, and then you get it right and you move on. Right? Whereas the thinking questions are harder because you have to think correctly, you have to get the question right, and then sometimes 2 or more answer choices look correct. Right? But this was just memorization. So memorize it, understand it, master it, and then in tomorrow's video, we'll continue on with abnormal uterine bleeding and more about pregnancy.